I welcome all the colleagues and guests. We are together on this occasion of World Stroke Day 2024, and we will be discussing about stroke rehabilitation, the past, present, and the future of rehabilitation. Now, I don't know if this day is to celebrate stroke, but I will start with a few statistics, and that is that stroke is a burden, not only on the patients, but a society overall. It's a social burden, it's a financial burden, it's an economic burden, whereas we physiotherapists are treating it as a physical burden on one patient. But if you look at the community, if you look at the family members, it is a bigger burden. And in countries like India, which are developing, in low-income countries, middle-income countries, the incidence of stroke is rising despite the awareness. And if you go by statistics, 10% of the global stroke happens in India. So it's a challenge on the healthcare system. And therefore, we are here to discuss how to prevent, how to raise awareness about it, how to treat better, how to get the patients recover better through physiotherapy. And we know that the important role that a physiotherapist plays in stroke rehabilitation, in determining the quality of life, participation, going back to work. It's a challenge. It's not just a physical challenge, but a challenge. And as a healthcare force, the physiotherapists are at the forefront, not only to care, but also to empower our patients in their life. So gathered today on this day, we have esteemed speakers with us. I would like to introduce Professor Dorcas. So Professor Dorcas is a vice principal and professor at College of Physiotherapy, CMC Ludhiana. She is also the fellow of Wellcome Trust UK, DBT India Alliance, and a future leader fellow of World Stroke Organization. And what we know about her is that she is a leading expert in neurorehabilitation and a resourceful person. I welcome you, Dorcas, and you can start your presentation.
Thank you so much, Dr. Harpreet. I really appreciate this opportunity. And I hope I can really do justice amongst the well-known speakers, Dr. Fayaz, Dr. Tarun, Dr. Karthik Babu, who was also partly my mentor, Dr. Karthik. So thank you so much for this opportunity. I'll quickly share my screen. I hope it is visible. I will be...
Yes, it is visible.
Yeah. So I will be speaking on the past aspects of stroke rehabilitation, of what had happened, the approaches that were used, and the whole idea behind how they thought about stroke rehabilitation in the past. These are my disclosures. I'll be using a little bit of information from various works that I do with these organizations. So all of us know the world has evolved humongously from the 1800s, even before that, till 2024. We see a lot of changes, not just in empires, but politics and sociocultural factors. Stroke rehabilitation also has evolved similarly. Just to begin with, the first time stroke was ever documented was by Hippocrates, the father of medicine, in the 5th century BC, and it was called apoplexy then, because the sudden onset with which it presents, it was called apoplexy, which in Greek means struck down by violence. And further here, if we see the causes of stroke was found out, either being the hemorrhagic or ischemic types, and this was identified by Dr. Webfer. 1800s to 1900s, the main focus was on the clinical phenomenology, pathology, the correlation between clinical and the pathological presentations, and the pathophysiology, of course. And unfortunately, not much progress was made except for finding the cause of stroke until the 1800s. In 1900s, we see very little attempt was done with respect to rehabilitation. Of course, medical aspects, there was a lot of focus, but rehab as such, not much importance was given. from the 1920s, we do see that medical professionals started showing interest in some form of rehabilitation. They knew that complete recovery during those days only through medical care was not possible. So they started looking at rehabilitation, but it was tedious repetitions of reading for aphasia. So it was a forced repetitive use on patients that was tried, passive movements, and various orthotic and assistive devices that were used then. 1950s, the condition was still a sad state. And I'd like to read this, this sentence that Dr. Barrow and Metz have written in their journal, and it really touched my heart. It says, patients then with stroke usually were at complete bed rest, waited on and pampered as individuals. Under these conditions, the patients usually deteriorated rapidly, and complications of decubitus ulcers, muscle spasm, atrophy, and infections were quite frequent. So this was the note that he wrote down in his journal, which shows a really sad state of affairs, where the assumption was that a stroke patient had to be bedridden and taken care of without being made to mobilize. Unfortunately, as many of you might be thinking, in various remote regions of the world, such a practice still happens, isn't it? So we really need to think a lot about where we are headed as a world. Systematic rehabilitation, however, the thought of assessing and treating the rehabilitative aspects only started in the second half of the 20th century. From 1917s onwards, there was an idea of interdisciplinary, multidisciplinary team approach for rehabilitation in certain urban areas of the world, in the Americas and the European region, and a little bit in the South America also. There are documents that they did seamless transition of care from hospital to the community, but this was only in the urban areas in certain parts of the world in 1970s. Then we see a major shift when outpatient rehabilitation centers opened, whether they were hospital associated centers or independent physical therapy centers. Patients started seeking rehabilitative services for stroke in the 1980s at these centers. And from the 1990s, of course, all of us know there was a large boom in clinical trials for stroke rehabilitation, as you can see in the number of clinical trials that happened for stroke rehab. Right from the 1990s, you see it steadily but exponentially rising. And this is continued till now. So a lot has changed, I think, from the 1900s, even the late 19th and the early 20th centuries. On the whole, if we see, rehabilitation initially was defined as a coordinated use of various services, but from the WHO, sorry, this was supposed to be a 2019 definition, not 2022. It talks about rehab as a set of interventions which optimizes function, reduces disability, and the key word here being it allows interaction with the survivor's environment, which is very key. And the World Rehab Alliance now, which is part of WHO, works towards such an implementation of rehab to integrate universal health coverage and to realize the Sustainable Development Goal of 3. I'm grateful to be a part of this. We talk about inclusion of rehabilitation in health policy, health systems, emergencies, workforce, things like that. So overall, again, in the past, many of these questions prevailed: effectiveness of early intensive rehab, patient selection, timing, location, etc. And again, most of us must be thinking, partly, most of these answers are still not, most of these questions do not still have answers to some extent, isn't it? So let's see how the whole approach towards neuroplasticity was in the past and how it progressed, because a lot of our approaches have evolved only because of the understanding about neuroplasticity. So back in the 1890s, this concept was first introduced by William James, and it was a groundbreaking understanding that brain can undergo ongoing functional changes, because before that, they considered the brain to be static with no changes after 5 years of childhood, where the brain completely develops. Just like the flat earth theory, so to say, not to raise controversy, but many people believe in flat earth. So this is how it was thought of. Later in the same decade, we had Dr. Eugenio Tanzi, who hypothesized that such an ongoing functional change can be triggered, and hypertrophy of neuronal pathways can happen if repetitive activities are given to the patient. So this idea came in way back in 1893 itself. The basic unit of the neuronal system, neuron, was described in the 1800s, late 1800s. In the 1897, the identification of synapse came in, but then they were not able to directly link it to plasticity or motor behavior or motor learning. Coming to the 1900s, the chemical basis for synaptic transmission was identified, and as in the theory was sort of proposed, not established. And this advanced the understanding of how changes at a synaptic level, be it chemical changes, that could influence learning and adaptation. And here, I think the whole understanding of motor behavior and learning changed to a certain extent, and practice influencing motor behavior kicked into the whole practice system, research world, I must say. But still, timelines and mechanisms of how these motor behaviors change was still a question. Until the 1915 and early 1900s, it was an assumption that only up to 2 years we see recovery happening, functional recovery, and after that it may be difficult, but that changed. So that's why even now we hear of physiotherapists and many rehabilitation professionals looking at recovery only up to the 6 months. And we tell patients that after 6 months, the recovery is going to slow down, there's not much hope. So we really need to be careful about the words we use and the things that we talk to our patients about, because there is potential for functional recovery, whether slow or fast. We do not have enough proof to tell them to stop rehabilitation after the 6th month or 2 years also. So earlier concepts, mechanisms for neuroplasticity included resolution of edema and diachisis, use of parallel pathways, and recruitment of ipsilateral pathways right from the 1915 itself. And more work has developed in the present scenario, which I think our next speaker will speak about. We see different aspects of plasticity coming in in the past of stroke rehabilitation. Cortical plasticity was established to produce motor behavior changes through Shepard and Carl Lashley's work on monkeys, the early primates, by restraining the affected limb in them. So this is nothing but CIMT. Of course, it was not called CIMT then. These findings were further strengthened by Tobey et al. And Gauthier et al. I think most of us in our masters must have read these papers, and showing that such therapies can increase cerebral matter density, and it further helped us understand the neuroplasticity and how it works. The Hebbian plasticity that we so commonly talk about, I'm sure in our journal clubs and lectures and conferences, started way back in 1950. And that is simply nothing but allowing the presynaptic cell to repeatedly stimulate the postsynaptic cells and shortening the duration between these two events. So for layman language, neurons that fire together wire together, and that is why we see a stronger motor behavior when such a Hebbian plasticity is induced or used in our therapy protocols. Lastly, in the late 1900s, late 20th century, we saw the idea of whole adaptive plasticity because of the anatomical finding that the brain has representations of multiple overlapping muscles, and that adjacent or remote subcortical regions take over when there's one area of the brain that is damaged. So this also came into the picture late in the 20th century. Of course, there's lots more done. I will not go into the details. We also need to remember that there are chances of negative plasticity that can happen through disuse. There are chances of aberrant or false hyperplasticity that can happen. So we need to be careful about the way we plan our therapy regime. So we understood a lot of research has been happening right from the 1800s. It's not something new. Research is not something new on stroke rehabilitation. But although the research was happening, it takes almost 17 years to turn at least 14% of our research for the benefit of patient as we treat them in the hospital and home. So although research was happening in the past, the practices that therapists did, or even doctors did, or nurses did, was very different from the findings in the research. From 1920s to 60s, we saw that they mainly used passive movements, like I said, the tedious, repetitive procedures for aphasia that was in fact painful for patients, then orthopedic and approaches like assistive devices, stretching, things like that. And we see two great examples here of patients with stroke, famous examples who were affected by these, I wouldn't say false, but less low evidenced therapies. One was the 28th president of USA, Woodrow Wilson, and he, in fact, hid his stroke. It's a very beautiful paper. I will not go into the details. I've given the link here. Please read about the difficulties he had to face then, because not much was known about stroke rehabilitation. And the other person was Vladimir Lenin, another politician, the head of the government of the Soviet Russia from 1917, again faced a lot of issues, had to undergo orthopedic surgeries and assistive devices, a really painful journey for the two of them. But we did see improvement 1960s to 80s. We had neurophysiological approaches being looked at. 1919 onwards, there was a major shift to task-based training. And 2000 onwards, of course, all of us are in the current era, and we look at a lot of qualitative rehabilitation regime, clinical practice guidelines, goal setting, specific dosages, etc. Later, people also started focusing on what can promote this neuroplasticity other than just repetition, other than task-based training. They looked at NMES, they looked at FES, they looked at forced use paradigms, very similar to CIMT, and the intense interdisciplinary outpatient rehabilitation programs, right from 1996 to continuing even now, I would say. A lot has been done on motor learning as well, not just motor behavior, but neuroplasticity and motor learning also was explored initially. And we have to remember, I've just put the key points here, that practicing repeatedly helps shape not just the motor behavior, but the expectations we have around that motor behavior for the particular patient that we are seeing. So what they expect, what they foresee. And this is the whole concept from which I think motor imagery and mental practice has developed. And when such a practice is combined with sensory input, it also assists in specific action selection, followed by the performing the action that is required, that is the exercise. People also started looking at how to do a particular practice. What is the type of practice we have to do? Blocked practice versus random practice? Should we do masked practice versus the different types of practice? They started looking at that, and they found various interesting findings. Two of which is blocked practice leads to faster acquisition of skills, but poorer retention and less transfer. And that was blocked practice. And masked practice allows for not a very rigorous retention or effective motor performance acquisition. So a few examples, I'll not go into details. With respect to outcome measures, we look at the very simple, very well-known Barthel Index being used right from the 1970s. And this was not just for stroke, although it started off with stroke, but the whole idea of Fugl-Meyer, which is a consensus-based scale recommendation for a stroke currently. The work on it began only in 1975, and it was largely based on the principles of motor recovery and Brunstrom that we still currently use. The advantage of Fugl-Meyer being it includes the idea of voluntary motor control, functional abilities of the patient, the coordination aspects that maybe Barthel may not give you a clear idea about the impairments per se. From the 2000 onwards, just highlights. Our next speaker, I'm sure, will cover a lot more about the current scenario. We have started looking at high-dose rehabilitation protocols, extended training hours, either at home or in the hospital, all of which shows structural plastic changes, reorganization of neural networks. We have also started looking at skill performance and the learning that can be enhanced by goal-oriented movements. If you see this word highlighted in green, I'd like to take your focus here for a minute. Contextual, setting specific goal setting, that which is meaningful to the patient, has really high chances of improving their motor learning and performance when compared to non-specific goals. And this is quite a big discovery, I should say, in the whole journey of stroke rehabilitation. It's not simple goal setting, but contextual goal setting. And lastly, of course, as we've been speaking for a very long time, experience and learning-based plasticity, which is core to the changes that we need in functional recovery. And we see how even other domains of rehabilitation like cognition, speech and swallow also are being explored, and how important it is to be included in stroke rehabilitation. So much so that it has also come into guidelines of stroke rehabilitation, that it is a must to at least assess them based on these things. It has all begun in the early 21st century. Types of learning, skill and skill learning, lots of details on this have also been explored. Doses of various mobility, upper limb tasks, the IMT mirror, various dosages have also begun to appear in our research and practice. So we see that from the olden times to now, a big shift has happened from strategies including task-based rehab, standardized evaluation methods, cost-effective service appraisals, emphasis on tailored community-based approaches. Different service delivery models are also being explored, because it's not enough to focus on the hospital based, but also in the community as well, where most of our patients end up in. The need for multidisciplinary roles, and lastly, the organizational structures that need to be in place for rehab to be seamlessly and smoothly given to the patient, and of course, the standard operating procedures. A lot has been done, and as I was preparing for this lecture, and thanks once again, Dr. Harpreet, for asking me to do this, the past, I've been so grateful to see how much work has been done by our pioneers in the field, by our seniors in the field, by our ancestors in the field. The road definitely is a long way to go. We have a long way, but with teams in place, I think a lot can be done. These are the various teams that I work with. And a special thank you to Dr. Rita, who's helped me put up almost everything on the slides that I've shared today. Thank you so much.
Thank you, Dr. Dorcas. A lot has changed in the past 2 centuries, and it was impressive how you could summarize 200 years in 20 minutes. And I'm sure that the past teaches us a lot, and that is the building blocks over which we step on to come to our present and to discuss the present state of rehabilitation. I welcome Dr. Karthik Babu. He is the professor and principal at KMCH College of Physiotherapy, Coimbatore. Dr. Karthik, we welcome you.
Yeah, thank you, Dorcas, for wonderful presentation. Thank you, the Neurophysiotherapy India team, for giving me this opportunity to present current technological strategies for balance and mobility restoration post-stroke. All right. So neurotechnology application in stroke rehabilitation are functional electrical stimulation, virtual reality, motion capturing system, robotics, neuromodulation, and brain-computer interface studies augmented with physical therapy. Salamet et al. In the review, they studied the application of neurotechnological intervention for stroke rehabilitation in Southeast Asia. There are a lot of published clinical trials from Singapore and Thailand. But in India, nowadays, neurophysiotherapy colleagues started using these advanced neurotechnological application in their clinical care. However, only a couple of educational institutions are using these technology in clinical trials. In one of our clinical trials, we studied the effects of functional electrical stimulation and physical activity on balance in community dwelling stroke survivors, where the quadriceps, hamstrings, dorsiflexors, and plantar flexors muscles were stimulated with FVS, while patients were performing 6 mobility tasks, such as walking, obstacle walking, walking up slopes, down slopes, stair climbing, and taking turn and sit to stand. So where we studied the outcomes, particularly on a Fugl-Meyer lower limb motor functioning, activity-specific balance confidence scale, we found following 8 weeks of FES and physical activity, we observed there was beneficial changes in Fugl-Meyer, lower limb functioning, and activity-specific balanced confidence scale. And we also recorded the muscle activity profile of these 4 muscles during a different walking tasks among community dwelling stroke survivors, those who walk with or without cane. The x-axis depicts the different activities. The y-axis depicts the percentage of maximum voluntary contraction. We found that there was a different muscle activity demand during different functional walking tasks, necessitating the muscle targeted rehabilitation strategies. And next comes the virtual reality that we are familiar with. Virtual reality is the use of computer technology to provide feedback that is related to posture and movement performance by allowing the individuals to interact with various sensory environment. So basically, in virtual reality, people with stroke perceive stimulated experience of real world. So today there are PlayStations, Nintendo Wii, and then Xbox Kinect, Gentronics, and other other consoles are available. There are 3 forms of virtual reality practice. In fully immersive VR practice, the patient or person uses a data glove and wear a head-mounted display, where the movement of body and the sensory flow of virtual environment are coupled. Next, in semi-immersive, particularly this consists of VR and real-world attributes by embodying objects of computer graphics into the skin of reality. And most often we use the non-immersive VR technologies. This is nothing but a desktop virtual reality. So where the infrared cameras or motion sensing input devices allow the user to interact with virtual gaming consoles. So we conducted one clinical trial using VR and compared this VR training with neurodevelopmental training. Following 4 weeks of training, we observed 3 points minimum detectable change on trunk impairment scale in a VR group. The task-specific NDT group also showed a similar effect. Okay. And nowadays, the VR is a boon for physical therapists to provide telerehabilitation services, particularly to train motor and cognitive recovery among stroke survivors. Next slide, please. Right. So we, along with engineers, we developed inertial measurement unit, that is wearable sensors, through BIRAC grant. So we developed this wearable sensors to assess the kinematics of gait. So we validated this inertial measurement unit with the gold standard Vicon engineering system. See on the right side, the top image that shows the movement trajectory of knee compared between our IMUs and the gold standard gait laboratory data. Right, it gives a kind of a validation for certain pitch kinematics. And what we had done with this IMUs, we also developed certain virtual reality platform augmented with these IMUs to enable functional mobility. Next slide, please. So this is the VR platform that we developed with IIT engineers. And also this particular IMU can interact with virtual platforms to enable mobility. So there is a ongoing clinical trial happening. So next. So we, as the physical therapist, we treat limbs, as well as nowadays we are concentrating on trunk recovery also. So it is not that we don't concentrate on trunk recovery, but there are many therapeutic strategies are there for trunk recovery. In fact, there are trunk rehabilitation strategies using VR and other technological options also available. The European therapy group have come up with a novel assistive instrumented robotic T-chair to train balance recovery post-stroke. So here the patient is harnessed and seated on a T-chair that has both motorized and non-motorized mode. In a non-motorized mode, the individual needs to do balance training as we do in a reach test. In motorized mode, it provides unidirectional and bidirectional movement. So that facilitates the postural control among people with stroke. So I was part of validating this particular device. So this particular device is augmented with VR, where the patient has to navigate a kind of a boat to the port, or should navigate through the canal by doing a weight shift. So this is a kind of technologies where the exoskeletal robots or end effector robots are used to train the balance recovery, augmented with VR. Next slide, please. Yes, robotic rehabilitation, there are mixed evidences. Even 10 years back, the evidence says that robotic rehabilitation is not superior to routine rehabilitation. Now, the recent times, there are a lot of end effector robots have come. Even therapists at the clinical areas do use end effector robo. Of course, the exoskeletal robo is very much expensive. Certain research institutions and certain hospitals are using them. But nowadays, we happen to find a lot of end effector robots used in clinical practice and research. Next slide, please. Right. The next comes the non-invasive brain stimulation. Non-invasive brain stimulation modulates the brain activity, central nervous system activity, by electrically stimulating the neurons in the brain. So there are two forms of non-invasive brain stimulation. One is the TDDS, transcranial direct current stimulation, and then transcranial magnetic stimulation. The next slide, please. The transcranial magnetic stimulation. So here the principle here is the magnetic field magnetic field developed through a figure of 8 TMS coil induced electric current. That electric current activates the M1 area, so where the neurons gets excited. So this results in excitatory postsynaptic potentials. That impulses will travel through a corticospinal tract and activates the muscles. So this is the principle. But what happens in following an injury? Typically, when there is an ipsilateral brain lesion, the intercallosal neural connectivity that is lost. Basically, that intercallosal neural connectivity is critical to have an inhibitory effect on both hemispheres. So when there is an ipsilateral lesion, the contralateral hemisphere cannot be inhibited. That becomes excited. So these kind of transcranial magnetic studies application is the lesion side is stimulated and the non-lesion side is inhibited. So this is basically the mechanism. So the mechanism works basically on long-term potentiation and long-term depression. So excitatory protocol is used with a high-frequency repetitive magnetic stimulation. Inhibitory protocol is used with low-frequency repetitive transcranial magnetic stimulation. Right. So the study showed that it produced improvement in walking and balance-related parameters post-stroke. I believe our Dr. Fayaz had done his PhD in TMS. He is the best person to give the insights about TMS. And lastly, the transcranial direct current stimulation. So here, the low intensity direct current is applied between two electrodes. And what is believed is that the current density that is applied through stimulation would determine the excitatory effect. approximately half of the current ingested during transcranial direct current stimulation is centered through scalp. So there are different kind of protocol is used. There are anodal stimulation and cathodal stimulation. Anodal stimulation is mainly having an excitatory effect. The cathode stimulation is having inhibitory effect. There are evidences for upper limb recovery with TDTS along with physical therapy, but there are limited evidence for lower limb because the close proximity of these lower limbs is quite difficult to provide the stimulation mode ipsilaterally and the similar mode on a contralateral side. Right. So there are a lot of developments happening in the field of neurotechnology, particularly in India. So we do practice a lot of technology in our clinical practice. It's a good sign. Many institutions nowadays started using this technology. So hopefully we will find more papers from India out of this neurotechnology in stroke rehabilitation. So lastly, I would touch upon one of the work that we had with the International Stroke Recovery Rehabilitation Alliance. So this is a consensus paper that gives the recommendations for using the clinical outcomes. So whenever we conduct a clinical trial, this paper explains about the different definitions of balance and posture, as well as we have given some kind of an insight about what kind of clinical measurement tools to be used when we conduct a clinical trial related to balance and mobility post-stroke. Yeah, next slide, please. So these are the certain definitions. This is open access article, and so anyone can download it and read. So these are the definitions, and these are the outcome measures that can be used. Depends on the fact category score below 3 and above 3. So that's all. Thank you. Thank you so much.
Thank you, Dr. Karthik, for sharing this presentation on technology. And I'm sure we know that now is the time that we can correct the course, and present is where the future belongs. And present is where we live. And as a renowned academician, we thank you for your participation. And I would like to welcome Dr. Fayaz at the same time, who is with us. He is a passionate researcher and PhD in neuroscience. He is an associate professor at the Faculty of Medical Rehabilitation Sciences at King Abdul Aziz University, Saudi Arabia. We welcome you, Dr. Fayaz, for being with us today.
Okay, good evening. Am I audible?
Yes.
Okay. Thank you, the organizers of Neurophysiotherapy India, Dr. Harpreet and Dr. Tarun, for inviting me. And I will also like to thank Professor Dorcas and Professor Karthik for giving a wonderful talk on behalf of the Stroke Day. And actually, I think it's my turn. They have handed over the baton to me to finish with the future perspectives in stroke rehabilitation. Well, the topic for today for me will be like use of artificial intelligence and machine learning in stroke rehabilitation. To start with, actually, like last couple of years, we were working on some studies on the like barriers and facilitators and perceptions of physical therapists on using AI or artificial intelligence in among physical therapists. So that made me thought about doing such a talk, like, because most of them have a like an apprehension of things that one point of time the AI would take over the job of physical therapist. Of course, no, because as we are using our hands, it won't be taken up. But there are some specialties in medical field which would be really completely taken over by the AI and ML. Well, the next point is that while doing a qualitative study, which was done, very recently, we could also understand that, the perception of physical therapist on AI is something less like something on the robotics. Of course, robotics is a part of AI, but it's not only about robotics. It's about it's a broad area that we would discuss today. So before starting with my talk, I would like to mention some points on AI. We are not going detail. Well, I'm not an expert in AI, of course. Well, AI or artificial intelligence, that term that we have heard a lot of time, actually it means a broad spectrum. It's a broad spectrum. And actually, it is AI is something beyond that humans can do. Or like, for example, like Alexa, from like voice to text, it converts voice to text. It can perceive or like recognize the voice, the visions, and all, and then give outputs which is beyond the control of humans. So it's called AI. And ML or machine learning, actually, it is a subset of AI. It works under the AI. What we do is we give some inputs, and it processes the inputs and gives an output that we need. So it is supervised and non-supervised. Well, deep learning is a more advanced form of ML or machine learning where, they do the processing or learning process in multiple layers or deep layers. That's called the deep learning. So I'm just giving a brief idea. Going directly into my talk. Well, in this talk, I would like to talk in 3 domains. One, the use of AI or ML in prediction models, and then the clinical applications and evidence-based practice. Well, for prediction model, that prediction of prediction of outcome is very important. Why? Because as a clinician who treats or rehabilitate a patient with stroke, of course, the first question the bystanders, the patient will ask is, doctor, when I will start walking, or when I will improve. So this question actually, if you ask us like a couple of years back, it would be difficult for us to answer. But nowadays we have a lot of prediction models with which we can really answer that questions. And there are a lot of studies have been done recently, which can give a prediction of from 60% to 90% of accuracy. Well, the basic format of prediction model runs within a model of the regression models. This is one of the studies that we had done recently, where we were predicting the community mobility with the trunk control of patients, which was, within the first week, 7 days, we were assessing the trunk control, and we were able to predict the community mobility, like around 80% of the community mobility is predicted by the trunk control. So this model actually is basic format of the AI or ML, which works with the regression model. The regression model, it's very common among us for working on research. Well, these are the factors. Hello? Yeah, so actually, can you hear me, right?
Yes, yes.
Okay. So regarding the factors, this paper actually defines the factors, predictors that we need to input or collect during our rehabilitation and input into the system. Actually, one point I would like to remind you is that, we are very poor in reporting or the documentation. So the thing is that we have to really document, then only the ML or the machine learning can work and give an output really. So the precision of the ML or the machine learning depends upon how well we input the data and the number of data that we give. So these are the basic demographic, clinical factors, and the genetic factors we can input to get a prediction model. So a lot of studies have worked with different models or different prediction factors. So we are just going into few. One of the preliminary studies that was done for the prediction of upper limb rehabilitation for stroke, actually, done by Quackel et al., the EPO study, like in 2012, it published, it seems to be. So actually, it was one of the best predictors, which I perceive like a SAFE score, that the shoulder abduction and finger extension. So if the patient has a shoulder abduction and finger extension score of like out of 10, more than 8, it has a very good prediction. Like they have done within 72 hours of stroke, and they have predicted very good recovery after 6 months. So this is actually one of the first prediction model that we have seen. Coming to the next one, which I like, there are a lot of prediction models, but which I took very few. This next prediction model, which I like, I liked was the study done by the Kathy Steen et al. In that, I think most of you know that PrEP2 model. They came up with the PrEP1 model in 2012. Later on, they modified to PrEP2 model, where they just used the SAFE score, which I explained before, the shoulder abduction finger extension score. Then they used the age, and they used the NIH score, and they use MEP, the motor evoked potential from the TMS. So that's only one we need as to be technical part. Otherwise, all the scores are just functional scores we can assess. And they categorize. So they took all the scores within 7 days, that within the first week, and they could predict the recovery of like in the 4 categories of excellent, good, limited, and poor. with an like accuracy of 75%. That means if you take like 100 patients, 75 of them had an like accurately predicted by this model. So they can categorize into like 4 categories. We will explain that later. But what is advantage of prediction? So they're predicting the recovery after 3 months. So in the first week, they calculated the model or formula, and they predicted the recovery after 3 months. What is expected recovery? So they can really plan and set goals for the treatment purpose. So we'll go in detail later on. Again, after 2 years after that, the same team headed by Kathy Steiner, they came with a very good a model for walking independently using just the trunk control test and hip extension scores. That really, it's very simple to predict. Like they can predict the walking independently within like 6 weeks or 12 weeks or dependent. So if the patient has a score of more than trunk control test of 40, will be able to walk in 6 weeks. So this is done within the first week. The trunk control test is done in the first week. Okay, and this model actually has a 95% accuracy in predicting the gait independence. Well, like if you look into the studies which has been published in recent years, it started, from 2016. There are studies working on stroke rehab using MI or AI or ML models, and now the rate of, you can see the graph, like it's increasing like more and more. Well, and there are studies which has been done on all the stages of stroke, like from the hyperacute stage, as I mentioned, within the first week, then in the subacute and the chronic stages. But I really believe that, if you're doing a prediction, it should be done in the first week so that you can give a good prediction after 3 months to the patients or the bystanders. Well, as I mentioned before, we need to input a lot of things like the outcome measures or the stroke parameters. So these are the outcome, the factors that we should, even the imaging parameters, which we need to input for predicting a proper model for recovery. Well, just something on technical part. There are a lot of softwares, or I can say technical specifications being used for the machine learning. Like you can see the first one on the left side, the A is the CART or the regression tree model, and the down C is just the regression model, and the D is as I mentioned, the artificial neural networking or deep learning models. There are a lot of models, but I was surprised to see a meta-analysis which they found, a study on, they compared between different types of softwares for predicting the stroke recovery using the ML. And out of that, they found that the DNN, the deep neural networking or the artificial neural networking, is the best one to predict with a better accuracy. Well, that's about the prediction model. Then I will just go into the clinical application. It's very briefly I have mentioned. So clinical applications on ML or AI, actually, it depends upon the machine. As we know, we use like robotics or virtual reality, and the evidence of robotics and virtual reality is not as much as compared to the consent-induced movement therapy or any other task-specific training. But the role of AI comes into where when we augment or incorporate the AI mechanisms into the virtual reality or robotics. Like, say, for example, I know there are some motion capturing cameras where the patient can, the cameras which will be driven by the AI, which can really capture the motion and can correlate with the real-time data or the data set that it's been there within the AI mechanism. So it can give you output of the deviations from the normal. So if you can incorporate or augment the AI technology with the robotics or virtual reality, it's really going to help you and making more precision in the evidence, or giving more evidence for these kind of technological rehabilitation technologies. Well, in the home-based care program, we can implement AI, for example, as the thematic diagrams, like it's mentioned here. Say, for example, if you have an AI mechanism, it can be implemented in the patient's home using like cameras or sensors, which can detect the movements of the patient. Then these cameras or sensors can actually send this information to the data sets where it can process it by using the ML or AI mechanisms. And this can be interpreted, and it can send back to the clinician or physical therapists where they can really make it fine-tuning of the process, or you can change the program or change the protocol of the rehabilitation as per the needs of the patient. So this is how a home-based program for AI works. Yeah, talking about the prediction model, we mentioned about the prediction of stroke using the PrEP model, the PrEP2, where they categorize the prediction or outcome in 4 categories, like complete, notable, limited, or none. So I mentioned that time that I'll talk in detail regarding that during the clinical application. So why we need a clinical a prediction of stroke recovery? Of course, say for example, if we can predict that the patient is going to recover completely, then we can plan or set goals for those rehabilitation techniques, which is for most of task specific training. Say if the patient has a limited recovery, expected a limited recovery after 3 months, we have to enhance more of muscle strengthening techniques, or which can strengthen muscles or go for strengthening techniques. And in the other way, if the prediction, or if the patient, a lot of times we encounter a situation that patient is not, we don't get any recovery. Like if it's a massive impact on the cerebral hemispheres, I have experience with the patient, even they rarely, just 10 to 20% recovery they have. So those kind of patients, if we can predict the patient that they don't get any recovery in 3 months, there is no, wasting time or efforts by giving technology or techniques for the upper limb or lower limbs or gait. Rather than that, I know it's not ethical or in our current practice, but rather than that, our ultimate aim for a patient is to make them independent aerial, right? So just try for compensatory strategies with the normal limb. So see, if you expect that the patient is not going to recover, then we can go for compensation to make them able to use the normal limb. So most of the time, what we do is we neglect the normal limb and go for rehabilitation of the ipsilateral limb, thinking that it will rehabilitate, we get rehabilitation. But with the odd time, when we expect that there is no recovery to happen in 3 months, we can go for compensations. Well, the last part of my talk, I would like to mention something on evidence-based practice. The evidence pyramid, as everyone knows, but this one, you can find the top of the evidence pyramid, the peak. You can find NMAs. NMA is the network meta-analysis. Usually you will find systematic analysis or meta-analysis on the top, but recently it would be overtaken by the network meta-analysis. So you will be, I don't know, some of you would be knowing about network meta-analysis, but however, what is network meta-analysis? So what is the normal meta-analysis? Actually, normal meta-analysis, what we can do, say, for example, if you want to check the evidence for robotic training for gait rehabilitation on stroke patients. So you just get an article of meta-analysis, which has worked on the robotic rehabilitation of stroke. And you can find only one technique, the evidence of one technique, and different domains of that technique. Say, for example, the improvement of cadence by using robotic device, or improving the balance, or improving step length. So you can get the evidence for one technique and different domains of that. But this surprised me, when looking at the network meta-analysis, you can really compare between the different techniques that we use for a particular aspect. Like for this study actually published 1 year back. It was on the non-conventional therapies for upper limb rehabilitation on stroke. So they have compared between all the available techniques that we use for upper limb rehabilitation. On the right hand side, you can find the network map or network diagram, where you can see the comparison, the width of the line, which says the strength of each combinations of studies that have been done. And the left-hand side, you can find the forest plot, where you can see the modified constraint inducement therapy is the best one for the evidences for upper limb rehabilitation. And after that, it's the high-frequency RTMS. Of course, I was wondering, when I started working in the PhD on year 2008, actually, that's the first time I was using RTMS, and we had very few number of studies. And then when I finished my PhD in 2013, there were few. But 10 years after now, I could see that, the high-frequency RTMS and theta burst stimulations are in the high end in the evidence pyramid. But let's say about the robotic therapies, if I remember 10 years back, if you say robotics were having the high end in the rehab and the evidence pyramid, so every time you have to update with the evidences to check how it is being changing. So every it may change depending upon the studies coming up, the recent studies. So for this actually to do an network meta-analysis, we really need help of a ML, like the machine learning processing. There are a lot of softwares which can work on it. So you can use ML, it can process for processing the different combinations of therapies that we use for a particular treatment. So this is another example using network meta-analysis for the balance training for stroke patients. And we can see that the core stability training is best for balance training. And after that, the whole body vibration is the best. And this one actually for the non-invasive brain stimulation, And you can see the network map, the strength and combinations of non-invasive brain stimulation with physical rehabilitation and sham stimulation. You can see that the strength of the studies and the combination of studies. On the right-hand side, you can find again the forest plot where you can find the TAVNS. It's surprised me a lot. The TAVNS, it's the transauricular vagal nerve stimulation. It has the most evidence, but see the patient number of patients is very less compared to other treatment techniques. Again, followed by that is the ITBS in the intermittent theta burst stimulation, which has more evidence of that. So this actually gives an evidence of combinations of different therapies and comparing different treatment techniques for NIBS. So anyway, TAVNS maybe which will change in the coming days when we have more studies about different non-invasive brain stimulation. Nowadays, we can find even the priming or preconditioning with different techniques, like preconditioning one stimulus with the other one. So we have different paradigms of doing the non-invasive brain stimulation. So what I wanted to tell you that, it can be, ML can also be used for evidence-based practice. Of course, we look into evidence for having to practice or select the best ones for our practice. Well, the last slide, which I like to mention, I don't know whether it's a real picture or an hypothetical picture, but I see that it won't happen in near future, so that it would take away our job. So I don't want to happen in near future. I think it's a hypothetical picture. Well, thank you for your patient listening.
Thank you, Fayaz, for sharing these insights about the future. And I think now is the time for course correction, because the future is what we are creating. And the amount of data, the amount of researches we have grown exponentially. And I would at the same time welcome Dr. Tarun, who is the session moderator. Dr. Tarun is a renowned clinician and an expert in neurological physiotherapy. He is the zonal head of physiotherapy and rehabilitation and head of neurorehab PanMax Healthcare. Dr. Tarun would summarize the session, and we will create thoughtful deliberations and engage in discussions at the end of the session. Dr. Tarun. Sir, your mic is muted. Dr. Tarun, your mic is mute.
Am I audible now?
Yes, sir.
Yeah, thank you so much, Dr. Harpreet. I think what an amazing session we had today, staging from past to present to future. And I was just looking at the messages from the audience. They were so keen and they were asking so many questions. So I would like to thank, first of all, to Dorcas for, first talking about how we actually evolved from the past, and especially when she was talking about the word which is the buzzword around is the neuroplasticity, and it was very well explained by Dr. Dorcas. I think nothing better than that, how she explained about the cortical plasticity and the bad and the good plasticity. I think that is very important for the budding therapist to understand what is a good plasticity and what is a bad plasticity. We at times, as a clinical therapist myself, we at times are so engrossed with the therapy, we tend to just shy away from looking at the task that we are doing. And it's very important for us to start looking at a patient from a biomechanical perspective, and to see what inputs we are giving. Are they actually helping the patient, or they are we are finding some hindrance in the recovery? Then going ahead with Dr. Karthik, very well explained about the present scenario, typically talking about the, assistive technology, what he spoke about, and very beautifully explained the role of FES, the functional electrical stimulation. I personally also, I'm a great fan of FES, and, we've been using that equipment in our clinical setups, and I have personally seen a great recovery to a patient, when we are doing with the manual. And obviously, it's a comprehensive approach. It's not just the FES, of course, it's the manual approach along with the FAS and other modalities. And then he was talking about virtual reality, which is a game changer, I feel, and I think, it has really changed the way the output, looking at the functionality of the patient, it has really paved the way for the future also. And then he spoke about the non-invasive brain stimulation, that's very important, I feel, especially talking about the, TMS or the direct cranial stimulation, these have really changed the scenario. Then coming back to Professor Fayaz, sorry, Dr. Fayaz, what an amazing lecture. I'm myself amazed with the prediction model that you showed today, and I'm sure, there are a lot of fans that you would have made today, talking about after your lecture, especially talking about the artificial intelligence and, how this intelligence can be used clinically in the hospital or in the home-based scenario. And, I'm sure, we may like to have a separate class or a session on prediction models. I would, myself would like to be part of that. I would like to learn about that more, because I think that is what is making a differentiator now. As a physiotherapist, a lot of times the questions asked by the caregivers, when is the patient going to stand? When is the patient going to walk? So if we have something objectivity coming out of it, why not use it? But of course, as a therapist or as a consultant, we have to be very careful what we are doing and what we are putting on the paper, because like we know, once you put it on the paper and the patient takes and the caregiver especially takes it in different way. And I'm sure, but all this is going to give out a positive outcome to the patient. And I'm sure, people listening to the session today, organized by Dr. Harpreet, should be really happy listening to it. And I'm sure, we'll have series of discussions on it.